I guess between January and March, there were 4 cycles. I think that's what it's saying. So over 2 months, 4 cycles, 2 weeks.
Okay, so calendar time, how delayed was the pseudo progression?
So 30 weeks
30 weeks?
if the cycle is 2 weeks, yeah.
And you think it's 2 weeks?
Uh, from the description, I think.
The reason why I ask is you have to write calendar time, how delayed the pseudo progression was in your paper. When you cite it, people usually want to know how delayed was that uh, report in the literature. Okay.
Do you agree with 30 weeks then?
I don't know. You should read the whole paper and decide. It's it's hard for me to read right now. So here you're saying 49 citation. What it notably later patient. This is our patient, right?
Yes.
One, yeah, yeah.
Yeah. Mhm.
Yeah, yeah. So you have to say, this type of cancer patient treated with this immunotherapy at what point of time show delay progression and supported by, a biopsy showing regression, all that detail I think is important. People want to know what.
In this section, in this summary section, or
Yes. Not in summary section. Summary, you should not cite anything. Well, you can cite it like that. But in the discussion, you have to talk about that case.
okay.
You can't cite a new paper in the summary section. Summary is summary. You're summarizing what you have already discussed before. So you should discuss the details of that paper in the discussion.
Okay.
When you mention, was delayed hyperprogression mentioned in the discussion?
I'll make it clear. Maybe like somewhere here.
Yeah, because you have to interpret this as a delayed hyperpercussion and say, there has previously been reported, um, you know. So for my learning, let's go back to that case. So one lesion was responding, but the right lower lobe lesion was getting larger and larger, like 8+ months. And they did a biopsy to figure out what's going on. And what did they find? Can you show me? Can you show me the paper?
Oh, are you talking about this case?
Yeah.
You can go to the abstract.
So left lower lesion is the delayed hyperprogression that showed necrotic and reactive inflammatory changes without residual malignancy.
So is this saying that the lesion got larger in size, but it didn't have any malignancy, even though the size got bigger? So it was just all inflammation?
Yeah.
Oh, I see. That's why it's pseudo progression. Okay, yeah, that makes sense.
Yeah. So because it's an interesting case, you should describe the details of the case in your paper.
Yes, will do.
Okay. Yeah, it's great that you found this paper.
Yeah.
Okay.
Everything else is still in progress. And then
So you're working on sarcomatoid, right?
yeah, it's taking time.
Okay. It's a very difficult cancer to treat. Sometimes it responds to sarcoma regimen, sometimes it doesn't. It's rare, but when it's sarcomatoid, it usually means it doesn't respond to common treatment options. So,
Yeah.
okay.
And then for transplant, I've been working with Dr. Wu on the pre-TN paper.
Mm.
I think he will present that to you in a few minutes. I have a question regarding the Discover paper or the Discover project.
Okay.
Uh, the team wanted to ask what we exactly mean by distant metastasis, and they gave out all these like list of organs. I think these all consist of what you mean by distant metastasis. It's just like any organ other than lungs, which is this for like calculating the time to distant mets for both mucinous versus non-mucinous and lipidic versus non-lipidic. Should I just reply that?
So give me a context. I, I update
Uh,
me on the original question and yeah.
yeah, so for World Lung, we are going to do like a time to distant mets analysis
Mm-hmm.
for both cohorts, like mucinous versus non-mucinous and lipidic versus non-lipidic. And the team wanted to clarify what we exactly mean by distant mets. And so they gave us these list of like organs where
Uh-huh.
mucinous or lipidic has metastasized,
Mm-hmm.
and and this list doesn't include lung. And so I'm assuming these are distant mets, but I just want to confirm with you before I say yes.
Does it have mediastinum?
Yes.
Mm.
And
So
like all these like lymph nodes too.
yeah. So, well, they say lymph node. We have no idea if it's hilar lymph node or not.
Yeah.
So you know mediastinum is N2 or N3,
Mm.
and that's not distant.
Intrathoracic as well too, right?
That's local. Um, so to be exact, we should take out mediastinum and intrathoracic. Lymph nodes that does describe it's extrathoracic is okay. Like intra-abdominal is okay. But if
Mhm.
it vaguely says lymph node, we can't, I don't think we can take that.
Yeah.
So when we do the analysis, we can take out the things that I just mentioned.
So these three mainly, right?
I don't know what other ill-defined sites are.
Oh, yeah.
I
Think
don't know what that is. Unknown
pleural
site. There's unknown site. Pleura is metastasis.
monotus.
So
Yeah. Okay, yeah, I think this is ready.
there's gum. Wow, eye. Wow. Lung cancer going to gum or eye is like,
7 cases.
wow. Heart? What is heart? One, oh, maybe they're talking about pericardial effusion, things like that. So
Mhm.
it's not heart muscle. Usually it's the pericardium. But you know, it's okay to just leave it. Um, okay, so do you think they have time to distant met the time information?
I believe so. If they didn't, I think they would have, yeah, mentioned.
Okay. Yeah, so I'm okay with this setting.
Okay. And then for OS analysis, since we submitted that like clinical characteristic molecular landscape of mucinous paper to ASCO, for the poster, they want to add the OS analysis for that cohort. And then for lipidic, we're going to aim for world lung.
Yes. So once you finish the draft of sarcomatoid, you know, definitely this is brief report you can write as a manuscript.
Okay.
Okay. Did we talk about which journal?
No.
So the lipidic, I I I, I think we'll see what we find, but I think we can combine it as a one paper, or do a two brief report papers, depending on what the final data looks like. I think we can start with JTO.
Okay.
So yeah, keep that in mind and work on actual manuscripts because we tend to submit the abstract and just it has to be one combined process.
Yeah.
Okay.
Yeah. That's all I have for today. Thank you.
Okay, great job. Let's keep going. And Monica.
Hello. Sorry for not being in the best shape.
Oh,
Uh,
okay.
I started with, I can share. Just give me. So I've started with writing manuscript a little bit. Of course, I'll have to go through each and everything with you once I get to the lab. Uh, for I started with putting different points, like what was, and I am slowly going to write them in sentences, but for now, this is how I have proceeded with like description of the cohorts, writing our inclusion and exclusion criterias. Obviously, this will be explained in sentences.
Show me the title.
Oh, I haven't changed it, but I will add it, the ones which we discussed earlier.
Okay.
Uh, and yes, so inclusion criteria, what was our exclusion criteria? Our workflow, what are the patients we excluded? A little bit about image extraction, and about segmentations, how many radiomix feature have we able to extract, and for model building up, I'm talking to Dr. Yuri about it. That's all I have done. It does look less, but it took a lot of time for me, given I did not have each and every, like I had to go and see to everything, like what was our criterias priorly, since I did not have any contacts with Dr. Gion for the manuscript part. But I will be able to finish the first draft by Friday.
Okay.
And working for EDW, just a little bit. I haven't been able to finish a very big chunk of EDW, but the other one is EDW, which I have been working on.
So for EDW, can you show me the timeline and where things are? And
The problem is all of us download the spreadsheet on our own computer and we edit locally, and then after we're done with all of our finished with all the patients, only then will it get uploaded. So none of us have uploaded anything yet. So I'll try to figure out. I'll ask with other people how much they have finished and if they can upload it before. I guess till Friday I will be able to give Liam or you the update.
okay.
Because we thought there, if we like make any changes in the main spreadsheet without understanding, it might be a problem. And that's what me and Sally decided upon, which I think is a good idea, because we want to have our own spreadsheet and then only upload it in the main page. If you can understand. But yeah, before I leave the lab, I will give a proper handover for everything to, if not you, but to Liam, I will.
Okay, great. Thank you.
That's true.
Okay. Let's go to Sally. Updates.
Yes. So talking about EDW for first screening, here's the update. So there we did 126 patient, screened 126 patients. So now we have 1,245 left. So hopefully, if we go in this pace, we will try to get it done in couple, like 2 to 3 months. I think that is our goal. But yeah, that's where we're standing right now. And then VC projects. So Eugene contacted me and he said the resubmission is delayed to I think 20, let me check. Eugene Kim, he said, oh, yeah. It's February 13th to like 20th. So it changed to like 20th. So he has more time to revise. And I also asked him what kind of comments they gave him, because I think it will be helpful for our other manuscripts that we're writing to like make any changes if we need to. So that's that. And then for my Grace Lee, like my project, I will try to draft the manuscript by the 27th. And then Emma and Eileen's one, I think they will submit. I think they're ready to submit. So they'll be submitting. Dr. Chae, I don't remember which journal you
Emma should know. I can't remember.
Okay, because you said it should be this one journal, and then if that doesn't work, then they can submit to translational cancer research, but I don't
Yeah.
remember which one the first.
I don't remember either.
Okay, maybe I'll ask Emma then.
But
And then,
who's submitting it?
Emma, I think Emma will be.
Is
Have you?
Emma almost done with the manuscript, right?
Yeah, they finished the manuscript, but I think our last conversation was how Dr. Chu is the first in the abstract, first author in the abstract. So that's something we need to still figure out. We're still in the we're still talking about it right now with Emma.
So if Emma is the one who did the most writing, she should be the first author.
Mm-hmm.
And let's just submit it as her first author.
Okay. Yeah, so I think this one's ready to submit, and then Dr. Yuni's project, it's submitted, but I haven't heard back from her.
So it's submitted for sure? Because I don't know if I got email.
It's submitted, but we didn't get any fee. Yeah, they didn't yeah, she said they didn't get back to her yet.
Okay.
But we put Pedro's name. Maybe that's why you didn't get the confirmation for manuscript.
Yeah, just follow up with her.
Okay. And then
And then was that submitted to SSRN? Because I want all four of it to be on as some sort of preprint.
yeah, so that I think I will be the ones to, because it doesn't matter who
Who
publishes,
submit?
right?
No,
Who
it doesn't
submits.
matter.
Yeah, so I think I will just work on that.
Yeah, just work on uploading it to all, yeah.
Yeah. So yeah, that's it. And then right now,
So today's Tuesday, so submit all four journals by the end of this week. That's just submitting.
yes. Yeah, we can do that.
But um
It is,
you can help them, you can teach them how to do it, but it's always the first author's primary responsibility to send it. So if they ask them, do you have bandwidth to send this week? If they say, I need your help, Sally, you send it for them. You're doing them favor. But if they can't, yeah, you do it. If they have time, do it by the end of this week, Sunday night. Okay.
yeah, well, I'll try to keep in contact with them. It's really difficult, but I will, yeah, I'll try. I'll try that. And if I don't get any response, then I'll just submit it by
Yeah,
Sunday.
yeah. That's what happens.
Um, and then other than that, I've been just working with Dr. Liam for dream patients, contacting them to get consent, and I'm building the red cap. I can kind of show you the
Yeah,
progress
show me
if
the
you
red
would
cap.
like. So, so we so far it's not done yet, but so far we have these different sections: snapshot, demographic, treatment history, and then we're gonna have a couple more. But basically, if you go in there, like these are the variables that we'll be collecting. Ministry. So I'm like playing around with the functions they have. For example, like duration of treatment, like I have to put in a code for AI to just calculate it on its own with the dates, like things like that. And then I think after we collect these data, we can get this PDF file format where it shows you like the entire data in one PDF. And I think you can also get it in spreadsheets. So this is where I'm at. I'm still building. So yeah, probably by next week I'll probably have most of the sections in RedCap.
Okay. Very good. So this is for all dream patients?
Yes, we'll be compiling their data in RedCap after it's built.
Okay. Liam, are we paying for the red cap? Is Dr. Barat paying for it? Or how
No, so there's a university grant that supports Red Cap access. So it's like a university-wide access that we have. So we're able to use it pretty much for free. Like we don't have to pay anything out of like the dream budget or anything like that. It's like a university-wide program.
Okay. Sounds good. Okay, Sally. Let's get the variants out ASAP. I want to forget about it after we just it's been there for a while. Talking about that, we have a pacemaker paper. Are you involved or is only Liam involved? Where's
I'm involved. We are done with the draft, but I think Dr. Liam, you said you're gonna read through it once and then we'll submit. I think we're ready to submit after that last.
okay.
Yeah, so I'm just gonna do one more read through it this week, and then we'll show it to you probably next live meeting.
Okay. That's been sitting there for too long, I think. Even that, let's get it out by preprint. Okay.
Of course.
So I don't want this to sit there too long. What journal did we decide?
Come again, please.
What journal did we decide to submit to?
I'll have to pull up the journals. Give me one moment.
So did we decide or not decide, or you don't recall?
We decided back then.
And you wrote it down somewhere.
Yeah. It's in
Okay.
it's in the Google Doc.
Okay, then just stick to it and submit. Okay. So after my final approval next Tuesday, let's submit it. Okay.
Understood.
Okay. Sally, that's for you.
Yes, that's it.
Okay, good job. All right, Aranus, do you have update?
Hello, everyone. Hi, Dr. Chae. How are you? So we've
Good.
been working.
I think you have to speak loud. Can't hear you well.
Can you guys see me?
I don't see your face. Now I
Can
see.
you see me?
Yeah,
Okay. Hello, everyone. So can you hear me now?
yeah.
So Dr. Chae, we were working on the table, and after the meeting, me and Dr. Wu will be finalizing it, and most probably we'll be done with it, and then we'll be moving towards the manuscript. And other than that, about the communication lecture, I'm so sorry I missed it because I thought it was today 6 a.m. and my time 6 p.m. But then I was confused.
Oh,
The
that's okay.
recording is not yeah. The recording is not yet uploaded, so I didn't see it, so I cannot provide any feedback. I'm hoping to see it. So in the next.
So Sally, you're gonna upload it today. You should be uploading it
The
today.
communication
Yeah,
one?
yeah,
Yeah. I'm uploading it right now.
okay.
I was really looking forward to it because I'm preparing for step 3 and communication is not very strong pursuit of mine.
So any updates on what you've done?
Um, the extraction for data table, we are doing that and we're almost done with that. I think Dr. Wu can update you like where he is at with the meta-analysis. So we're just at the table. Yeah. I showed you that in the last meeting as well. So I was like,
Okay, very good. Thank you.
thank
Okay,
you.
Dr. Wu, can you give me your update?
Yes, so for the last week, I am mostly focused on the manuscript writing for the pre-transplant malignancy topic. So I am working with Hassan. So let me show you the ones. So abstract is same as the one that we submitted in ASCO. And then we are finalized. This is introduction part. And introduction here, method, result section, discussion section. So the primary manuscript is almost done. We will finalize the content and the references for the manuscript. So I think that it will be ready for you to review next Monday or this Friday. Yeah, that is our goal. So we have been focusing on this topic and we will finalize this. And later, I think the priority for manuscript will proceed on the graft failure and post-transplant malignancy according to organ types. Then the manuscript for the metastasectomy will go on. So for metastasectomy, so among many primary cancer types, Aranus is in charge of sarcoma cases, and head and neck cancer is done by Brandon. And they are filling up the tables, but still there are a lot of blanks. So they need to fill up these areas. So I'm communicating with them to finish this table so that I can finalize all meta-analysis for these two specific primary cancer types. Yeah, that is the progress about the metastasectomy.
Okay, very good. Yeah. Did you look at Steve, the court C patient's case?
Not yet. I've
Yeah.
not yet seen cases.
So why don't you look at it today and tell me what you think? Because Steve Cannon,
Okay.
so from the diagnosis till transplant, let's figure out this patient really was free of cancer, or was it Nivo rendering him to be in CR, or because he didn't have any cancer when in the exit transplant. So I want to make sure we know exactly what's going on. So study this patient and let me know when you're in the lab, just come and find me and let me know what you think. You have to go through all the CT scans, look for yourself and see if it was really responding to chemo before. The wedge resection was confirmed cancer. However, all the other nodules, do you think those are granuloma or do you think they were cancer and then chemo cured them all? We need to have a reasonable interpretation of what actually happened before we can assign them. So okay, so work on that, and you, Liam and Sally should work with Tarek on writing the cohort A and C. Just help him write the actual paper. Cohort A and C. C, there's a lot more patient, but he was just able to get 4 patients. So Sally and Liam, make sure you have a good list of who's in A and C, and make sure they are truly eligible. And follow them real time. Who got the transplant? How are they doing? Michael Goldston just got new lungs 2 days ago, so update that. He's doing well. I went to see him with Monica yesterday. It was Monica's first inpatient rounding, so it was good. He was really thankful he got new lungs. Yeah, I think once you are on oxygen and on the list, I feel like they get it in 2 to 4 weeks time period. So it's really amazing that it's happening so fast. Yeah. But obviously, I was so sad when after Albert Curie, there were two other patients that were exactly like Albert Curie, and they died just waiting for lung. And they waited like 4 weeks and went into DIC and died. Been on ECMO for too long. So Dr. Wu, question for you. Like, how long can one be on ECMO safely without complications?
What does it mean?
Uh, can one survive on ECMO like 6 months? Because
I
it
have
has.
seen the patient who survived 6 months of ECMO and had got lung transplant and discharged after 6 months in Korea. But
Wow.
it was very rare cases, after starting ECMO itself is becoming, I think, problematic.
Yeah.
So usually within a week or two, it is the best time for them. But after that, there are many, some we call it is not side effects, just complications of the ECMO itself.
Hmm.
So
What
yeah,
are
as
the
you mentioned.
common side effects that you have seen?
So ECMO is, as you know, is a extracorporeal circuit. So it itself causes inflammations and some what hemostatic complications, also bleeding. So bleeding is most common, I think. So it can be some just bleeding from the cannula side, but it can be also, as you mentioned, DIC or other problems. Some people experience heparin-induced thrombocytopenia.
Hmm.
Also, so those are the major complications, I think. But some experience stroke or hemorrhage in brain also. Yeah, that is the most problem. And as long we have more period of ECMO, there is problem of infections because most of them are, in ICU and they are in bed ridden states for a long time. So it lowers the chance of recovery even. So usually for a lung patient, we are trying to use awake ECMO. We put on ECMO, on Bino ECMO, and we try to then wake up and walk and eat and exercise. But it requires a lot of team care, and it's not possible for all patients. So
Hmm.
yeah, there is some difficult part, I think. So for heart, they have a valve which can be put in the chest. They can they can wait until they receive heart transplant, but
Right.
for long there is not a kind of the things right now. So I heard that some are researching about artificial lungs.
Yeah.
Yeah, that is also another topic. And artificial heart will becoming very popular soon.
Oh, really? That
Yeah.
close? Mm.
Yeah.
Because bad is like artificial heart. It's bad, right?
Yeah. But artificial heart is totally and replace the heart with the artificial machines and
Hmm.
yeah.
So
About it.
is
Yeah.
there a difference in, because our heart is pulsatile,
Yeah.
right? But then VAD is like continuous flow.
Yeah, continuous flow. So some they think it is same, but they think the pulsatile is much physiological. So
Oh,
some are inventing some bad types such as pulsatile. They
oh,
make it is also area of very big research. So yeah, some pulsatility may be necessary for physiology functions. So still is in development, I think.
hmm. Okay, okay.
I'm sorry I'm
Uh,
cutting you off both, Dr. Chae, but I just really hope whenever I'm doing observership with you, I just see a patient with double lung transplant because that is something that I have only read about articles.
hmm.
I have never seen a patient with lung transplant.
Oh yeah, you come here, you'll see them very frequently. So
I was discussing this with my brother. He's a physician in UK, and he was shocked. And he was like, "You need to send me pictures if you see one."
yeah.
If you see that it is very gross and very just a bunch of
It's
work.
because in Pakistan, there's like not even a good care for primary sarcomas or for primary tumors, and then metastectomy and double lung transplant. It's just like something we can only imagine. So just seeing that, I think it will be such a good experience.
Hmm.
I'm excited from now.
So, Dr. Wu, let me uh tell you to do a journal club next week. Let's talk about ECMO.
Mm-hmm.
It could be a brief 10 minutes.
Okay. Yeah, okay.
Talk about ECMO, the concept, physiology, history,
Mm-hmm.
and your own personal experience and indication and complication, yeah, all of that. And then you can talk about the difference between the cardiopulmonary bypass during the operation and uh yeah, and Northwestern, we do it a lot. And uh I don't know how, because I think it's a big breakthrough in before the ECMO era, people just died, right? Like they couldn't wait. So it's really life saving procedure in the machine. And then also talk about future, like what do you think the future is going, how small will the artificial lung will get? It's all about bioengineering, and we are, we want to talk about it as I think we are. So this is like a field is thoracic transplant oncology. We're gonna call this because we have abdominal team that it's the field is there already, but thoracic is not up to date. I know thoracic surgeons will love it, but the thoracic medical oncologists are not up to par. And they really need to be updated on all these the thoracic advances that we've made. And I think ECMO is a really revolutionary thing that we were able to do. And what I was shocked is our patient Alba's, um, and what's her full name, Liam? Alba's, uh, you have a patient list there? Her name and
I'll have to look it up.
Hesong, do you remember her? Alba's? Maria used to
Um,
go to look, translate for us for this
isn't it
patient.
Guadalupe?
Yeah, Guadalupe is her first name, right?
Yeah,
Guadalupe Alvarez. I think that's her name.
yeah.
Yeah. So the reason I'm mentioning her is because you have to while you're on ECMO, you have to be strong. You have to have muscle strength and right. So with ECMO, she would walk around the whole ward, and the machine was following her, right? And then all the physical therapists, everyone, like 4 or 5 of them, were walking with her so that she can walk in the ICU. And just to watch that was, oh my God, you know. But she was like 75. I don't know what's South Korean cutoff for getting lung transplant. Age cutoff was, or I don't know if there's one.
They prefer on the 65, but now many are attempting over the limit. And
Okay.
in Temple University, I think they presented good outcome among 70 and 80s.
Oh,
So they are
80s.
now-
Oh my God.
so they are people.
Yeah, I think Northwestern is 75. I think Korea's European country is 65. It's same with the, let's say, bone marrow transplant. Yeah, America likes to push, but yeah, you can't get like bone marrow transplant in 70s if you're in Europe. It's yeah, it's a social, it's, yeah, it's the reality. But anyway, let's talk about that next week. Dr. Wu, if you can prepare a nice short presentation.
Okay.
Okay, good. Keep up the good work. Okay, Liam.
Right, so I don't have too many updates today. We're working with the students on finishing the EDW, and we're building the REDCap database for the dream patients so that we can start putting all of the patient data into REDCap for future. So far we only had like a handful of patients, so kind of data mining and reporting on their cases was relatively easy. But you know, as we plan for the future, if we're gonna get up to 150 patients, like I think collecting and organizing all the data in REDCap will be useful, you know, looking to the future. So we'll get like the first draft of that ready soon, and then we'll show it to you so we can get feedback and add and subtract variables, and you know, figure out how best to optimize and structure the data set.
Okay.
And one thing with so contracting wise, I think I can just talk to you
Yeah, yeah.
separately.
Yeah. Talk with me about contract separately.
Yeah. Um, that's pretty much it for now. I mean, we just finished the ASCO submissions last week, and we're preparing. So we should start preparing for the AACR posters, and also World Lung abstract deadline is in April.
Okay.
So just enough time to, I think, finish all the posters. I think the poster deadlines are like a month from now, and then World Lung is another month from that. So
Okay.
and that's for me for now. Other stuff I can go over with you in person.
Okay. Very good. What about the last trial? Any updates since our sim?
No, so we've requested the information from Akizo. I think they're on like their long Lunar New Year's holidays right now, so we're just kind of waiting for their response.
So is it nothing's on our court? Did we?
Yeah, as of right now, there's nothing on our court. I think the protocol writers are still working on the edits we discussed at the SIM, and then I think the disease team meeting is like tomorrow or something like that. And then SRC will be after, but and the lab manager, the PCF lab manager, I forget his name, he didn't reach out to us. I don't know if he might have sent you a separate email, which I doubt, but yeah. So right now we're just waiting.
Lab manager? What do you mean?
So remember there was the person from the lab that wanted to discuss the lab manual for the last trial?
Uh-huh.
we ran out of time, so we weren't able to discuss any of that with him. So he said he'll just email us.
Oh, okay. Yeah, let's look. I don't know if yeah, let's find that email. If it didn't come, like let's just email them. Let's get this out of way. We don't want to sit on anything. Let's work on that. Okay.
Then Hugh, we're setting up a meeting with Hugh for the last trial budgeting.
Okay.
So we'll talk with him about that. And then for the other child that are trying to write with Tarek, we got the email saying you probably should talk to like the division leadership first about the use of cancer center funds.
Yeah. So that's the mucinous trial.
Yes.
Yeah. I talked to Terry girl about it already. So okay. Hansel, why don't you follow up with the SIM email with the medical writer? I know you've been working with her. Ask her if there is anything that we need to help out on finalizing the manuscript. Because I don't want this to sit too long. Email CC Liam and me, and if there's any help she needs, help her so that we are done with the protocol.
Okay, yes.
It would have been great that you would stay till the last minute, but whatever you missed, I'm hoping Liam gave you updates and really, just finalize it together with her.
Okay, we'll do.
Because this is the most important priority right now we're focusing on. We don't want to delay anything. Okay. Okay, Haesong, do you have the journal club ready?
I do.
Okay.
Oh, and Dr. Chae, one more thing. The redefining hyperprogression, the paper that Arnie submitted with
Yeah.
Dr. Yu. So we're working on it. They're traveling apparently for their PTO. So they're in Indonesia and Korea. They're coming back like today and tomorrow. So, but they're working on it like right now. So they said they're gonna send us the draft for your review and approval by Thursday.
Okay. Do you know when the deadline is?
Deadline is Friday. Oh, Saturday. It's the 17th.
Okay. So, Liam, maybe you or Sally need to grab me and print it and get my comments and send back to them, and then they should get it back by Friday.
Yes.
Because I cannot, they shoot me an email. I don't know, I cannot, do that. So have them email
Yes.
you, and then you print out their questions, and I'll give you my comments.
Yes, that's the plan. We'll do.
Okay.
And did Richard talk to you about the ACC paper going to BMJ Open?
Yeah, I said I'm okay with it.
Okay. Okay, and that's it. Done. Thank you.
Thank you.
Wait, sorry, one sec. I'm having some like technical issues with my iPad.
So, are you ready?
Yeah, one second. I'm having a bit of technical issues. Sorry, if anyone else has anything, sorry. I have this like script written on my iPad, and my iPad is updating right now.
Oh, okay.
It should be done soon. Okay. Okay, so this is a study conducted by, wait. Wait one second. Okay. All right. The study was conducted by the Dana-Farber Cancer Institute, and it was published in Biology of Neoplasia. They presented the genomic and immunophenotypic landscape of acquired resistance to PD-L1 blockade in non-small cell lung cancer. Purpose was to explore the mechanisms of acquired resistance to ICI in non-small cell lung cancer. They conducted a comprehensive tumor genomic profiling, as well as machine learning-based assessment of TILs, kind of like LUNET-scope. They also used multiplexed immunofluorescence, as well as HLA-1 IHC on matched pre and post ICI tumor biopsies from patients with non-small cell lung cancer treated with ICI who developed acquired resistance to ICI. They added 2 cohorts of patients with intervening chemotherapy or targeted therapies between biopsies, and they were used as controls. Briefly, they ended up including 82 patients with non-small cell lung.
Can you go back to the title? I'm sorry. So what group is this?
Dana-Farber.
Dana-Farber. Mark Awad. Okay. He's the corresponding author, right?
Yes.
Okay. You go to the purpose. So in this ICI, do you know if they looked at monotherapy or combo?
They had both mono and combo.
And here they only looked at acquired, not primary refractory cases.
Correct. Yes.
Okay, so that's the unique part because some of them will just combine both of them, and just yeah, not dissect the difference between the two. Okay, go to the method. So the unique thing is they applied machine learning based assessment of TIL, just like what we're doing with LUNET. And they added HLA. And we have that data. If you look at Tempus, we have the HLA phenotyping. So we can look to see what validate any of their findings as well. Okay, go ahead.
Yeah, so they examined samples from 82 patients with non-small cell lung cancer, and compared findings with a control cohort of patients with non-ICI intervening therapies between biopsies. So in chemotherapy group, there were 32 patients. In targeted therapies, there were 89. And then combined group, there were 17 patients.
Okay.
What's shown here are only the acquired genomic alterations in the post-ICI biopsy that were not present in the pre-ICI biopsy. And so the genomic changes at the time of acquired resistance to ICI were identified in 62% of patients. So that's 49 out of 79 patients. And the variants predicted to be benign or originating from CHIP are not shown. And the driver mutations shown in the oncoprint, these represent mutations identified at baseline before the start of immunotherapy. And if you see here, these patients had PFS over 6 months. These patients had less than 6 months. PD-L1 positive are these patients, and then patients with both PD-1 and CTLA-4. Oh, wait, I'm sorry. It's not the expression. It's the ICI therapies that they received. So this is the one I wanted to show you earlier. So this is
Oh.
PD-L1 or one monotherapy group. This is combined PD-1 CTLA group, and then combined PD-L1 plus chemo group.
I see. And the next purple?
This is the response type. So complete response, 2 patients, partial response are these patients, and then stable disease.
So I wonder why they didn't show that for the PD-1 mono and CTLA-4 combo.
Oh, like subgrouping?
Oh, now I see. Okay. That CRPRSD regardless of the treatment. I you know, I was
Right.
just thinking, yeah. Okay. So this is really nice way to create table. I like this. Because one table you can see what individual patient got and their response and whether they are acquired or not, just going by the 6 months. So 6 months is an arbitrary clinical cutoff. Like if you progress after 6 months, we're gonna call it acquired, less than your, I guess, primary refractory. But what's interesting is, you know, if you look at PR and if you look at PFS 3 to 6 months, you know, their initial scan was either PR or SD, but probably the next scan or the following scan, scan number 2 or 3, showed progression. So these are, we're probably going to call them not acquired. Yeah, so my point is we have to understand there's this arbitrariness in, you know, defining who's acquired, who's not acquired, because we're kind of all, you know, all in this analysis, we are excluding the first scan that showed progression. No one is first scan progression here. So we're asking a unique question. Among patient who had disease control in first scan, can we see meaningful difference between the acquired resistance versus not? And Haesung, what do you see in terms of the mutational landscape? What's the message you're getting out from here?
Well, it's so this meaning like the acquired loss of function mutations are mostly seen in the STK11, the B2, so STK11, B2, and APC, mTOR, KEAP1, and then JAK1, 2. These are the main acquired loss of function mutations seen here. Or at least that's what the, yeah, that's what the authors said in the manuscript.
What about JAK1, 2?
Yeah, it includes JAK1, 2 as well.
And homozygous deletion happened in PD-L1, 2, CDK 2A and B. So that's really interesting as well. MYC MDM2, MDM2 has been one of the suspected culprit of immunotherapy resistance as well. So we see that here. Yeah, beta 2 microglobulin. KEAP1, SMART4. Okay.
Next in this figure, you see the pie donut plots depicting the rate of acquired mutation at the time of resistance to PD-L1 based therapies, to chemotherapy only, and to targeted therapy only in patients with non-small cell lung cancer, and matched pre and post-treatment tumor genomic profiling. And in the bottom, you see pie donut plots depicting the rate of acquired copy number alterations at the time of resistance to PD-L1 based therapies, chemotherapy, and targeted therapy. And the labels of genomic alterations uniquely identified in the PD-L1 based therapy cohort are in orange. So here you see STK1, B2M, NF12, APC, etc. So these are unique to PD-L1 based therapies.
Those are unique. Okay. So chemotherapy only, nothing.
In terms of mutations.
That's really interesting, right?
Yeah, I guess they don't have time to develop mutations because they just die. Like it's just like yeah. So all this
And
was just done. Okay.
targeted therapy, is that mutations in EGFR gene and PIK3CA gene and 89. That's a lot. Oh. Okay. Okay, go down. The copy number alterations. So there's amplification, but more loss. Heterozygous loss is the most common. Homogeneous is less common. So chemo, you do see some loss in copy number. Targeted therapy, still there's a lot. Chemo, immuno, you know. Oh. Okay. And these are all acquired resistance patients? Are these
Yes.
all like all acquired resistance? Okay. 79. 79, that's a lot of patient. Can you go back up to the
This one.
how many patient is this?
This is also 79. Well, yeah, 79 patients because this is only ICI based cohort.
So because what you showed me is 79 is chemo plus immuno combo.
Well, like it's the same patients. Like it's plus or minus. So this also includes plus or minus.
Oh,
IO
so
minus.
everyone combined. Oh, it was plus or
Yeah.
minus. Okay, okay.
Yeah.
Plus or minus. 79. Okay, 79. Okay, they're the same patient. Okay, just want to make
Yeah.
sure. Okay, next.
And now let's see. The ABC. So these are the paired box plots showing the change in the density of TILs. That's A in macrophages and then in neutrophils among patients with matched H&E stained slides before versus after intervening IO, chemo, and targeted therapy. And then immune cell density was quantified on digital path imaging using machine learning, and the representative images of a pre-ICI sample and a matched post-ICI tumor sample that underwent immune cell quantification are shown here. And this reflects a significant decrease in TILs in the IO resistant sample.
Decrease in
TILs in the IO resistant samples.
and these are all acquired, right? These are all
Yes.
samples. Okay, let's go one by one. The first A, lymphocytes go down in chemo plus minus immuno, but there was no other. So downtrend for lymphocyte. Macrophage, no trend. Neutrophil, no trend. So it's the lymphocyte that's decreasing in acquired resistant cases. And also in the tumor microenvironment, it decreases. Yeah.
Right.
Okay, so the resistance is really like if you take out the lymphocyte by turning on different pathways like STK11, SMART4, well, I guess not turning on, loss of function. The lymphocytes get depleted. Okay.
Here, ABCD, these are paired box plots showing changes in CD3E plus, CD4 plus, CD8A plus, and PD1 T cells in patients with pre and post ICI tumor samples that underwent multiplexed immunofluorescence. E is the paired box plot showing a significant decrease in PD1, PDL1 engagement at the time of acquired resistance to ICI. Then F and G, these are representative case of a patient with pre and post ICI multiplexed immunofluorescence showing significant decrease in tumor infiltrating CD4 and CD8A T cells. So from here to here, you see a decrease in those T cell populations. And then H, these are paired box plots showing significant increase in the neighbor distance between tumor cells and CD8 plus PD1 positive T cells at the time of acquired resistance to IO. I and J, these are representative ray plots showing increase in the neighbor distance between tumor cells and CD8 positive, PD1 positive T cells between pre and post ICI tumor samples.
Okay. Pretty good. Very, yeah. Very intuitive and nice figures.
Now it's the final figures. Here you see paired box plot showing absolute changes in HLA class 1 H score among patients with pre and post ICI chemotherapy and targeted therapy tumor samples that underwent HLA class 1 IHC. B, it's the percent change in HLA class 1 H score among patients with pre and post ICI chemotherapy and targeted therapy tumor samples that underwent HLA class 1 ICI. Here you see a representative case of pre and post ICI tumor biopsy showing significant decrease in HLA class 1 expression at the time of acquired resistance. Here you see a change in B2M expression by H score between pre and post ICI tumor samples, and individual acquired mutations are reported here as well. And finally, representative case of decreased B2M expression by IHC in a patient with acquired B2M nonsense mutation with concurrent B2M missense mutation.
You go up.
Yeah. Oh.
Oh, yeah. Yeah, so only in ICI group there's, well, there's a trend towards decrease. Um, absolute difference in HLA1 score. And for figure B, is that post-treatment score? All three? Oh, absolute difference?
Yeah, absolute difference. Yeah. Mhm.
So this
Absolute.
is post minus pre difference?
Yes, post minus pre. Yeah.
Oh, okay. Hmm.
So you see a difference between ICI versus chemo only.
Hmm. Okay. Yeah. Very interesting way to show it. Yeah. Okay.
So to summarize, putative resistant mutations were identified in 27.8% of IO-treated cases. This included acquired loss of mutations in the following genes, and these acquired alterations were not observed in the control groups, meaning the chemo-only, targeted-only, or chemo-targeted cohorts. The immunophenotyping of matched pre and post ICI samples demonstrated significant decreases in TILs, especially the CD3E plus and CD8A plus T cells, as well as PD-L1, PD-1 engagement. Increased distance between tumor cells and PD-8 plus, PD-1 positive T cells were observed. There is also a significant decrease in HLA class 1 expression in the ICI cohort at the time of acquired resistance compared to the control cohorts.
Okay.
Yeah, so finally, these can be considered when developing novel strategies to overcome resistance.
Good, good. Very nice summary. I think you explained it really well, and I feel like you understand the biology. Good. Now, with studying all this, what do you think will be the next step? Like, if you are in this field of immuno-oncology, what do you want to do next to bring this finding? By the way, what journal is this?
This is biology of neoplasia.
Okay. So with that, what biology of neoplasia? Huh. I'm not aware of this journal. Anyway, what if you are active researcher in this field, what kind of research would you like to do to apply it to your patient?
I I mean, with these identified acquired resistance genes, I may be careful in considering IO when these mutations are identified in like the Tempest reports, this DNA reports. For further testing, I could consider these like immunophenotyping, like the pre and post ICI samples if ICI is given.
I didn't quite get you. So what would you do?
I'm not too sure.
I can give you so here's the thought frame. A lot of things we do here. So again, this is I really like this research. The reason I selected this is they were able to do acquired resistance biopsy. And how many total? 75 for immunocontaining, right?
79,
But then
30.
they also got 30 and 30, 89, right?
Yes.
Yeah. So that's like 194 patients. And that's a lot. Almost 200 patient has had to consent to getting an acquired biopsy, which we normally don't do. Okay. How many times have you guys seen me do acquired resistant biopsies? Not often, because for patient it's a unnecessary risk. They can get pneumothorax, hemothorax. Biopsy is not easy. So Dr. Wad probably done it under clinical trial where they consent and he got the funding to do the biopsy as well as run all these analysis. So a lot of funding and effort, and I can see, 2-3 postdocs work full time on this project. So anytime you do project like this, you can kind of sense what a daunting task, like 200 patients to get all the clinical data and all the molecular data out, and do these neighboring cell distant translational work. So I think Haesung, you're in a perfect position to kind of feel what that kind of workload is, and all that. Because working with me on the DART and the translational piece, not easy, but they've done it. So congrats to Dr. Watt's team. Now, with all this hard work, where do we want to get to? So I want to emphasize on what's next. Always, if you want to be critical, if you go to any meeting, Haesung and I went to Singapore, and we listened to many researchers present their findings. And once you do that, once you hear their presentation, uh, the questions that we can ask, or the questions that we get as a presenter, is usually, what's the next step? So with all this finding, how are you going to apply it to better our patients' care? So here's the thing. So a lot of studies, even in our lab, what are we trying to do, Sally? And the why are we setting up the data? So number one, we want to know, with the pre-treatment variables, can we predict the future? But the answer might be no, you can't. You just have to do rebiopsy to find out if there is a new acquired mutation. It's all genetic. Cancer is a genetic disorder. So you need to do a repeat biopsy, find out, because it just acquired in that clone. It's probably not going to shed in the blood, and blood may not be enough. Who knows? No one knows. So I would say the next step might be, can we use blood? Because we're doing serial blood anyway. Can we do the most sensitive ctDNA assay to pick up these mutations to genes in STK11, KEAP1, SMARCA4, and we have the beta-2 microglobulin gene. We have JAK1/2. And some of the data created here are already first demonstrated by Dr. Daniel Shin at UCLA. He had a cancer discovery paper that talked about very similar concept, only in melanoma, not in lung cancer. So this is not a new finding, but it's new finding in terms of comparing to chemo, comparing to targeted therapy, and looking into just the non-small cell lung cancer space. So that's where the niche is. That's why this didn't get to a better journal. Oh, is this JCO?
Oh, wait, what?
What did you say?
Um,
Oh, it's a biology of
I
neoplasia,
guess yeah, it's a sub-journal. Is that what it is?
but it's under JCO. What does that mean? I think it's JCO.
Yeah, JCO. Yeah, it's yeah.
Wait, JC, is it JCO a different journal within? JCO made a sub-journal?
It looks like it.
Oh, wait.
These are all
Oh, no, it's a category.
article type. Oh, I guess it's just the article type. Yeah, so it's JCO.
Oh, it is JCO, right? It is the, yeah.
Yeah. Sorry about that.
Well, it's okay. JCO is a really good journal. So,
Yeah.
anyway, what I'm trying to say is, the question is pre-treatment variables not enough? Do we need to get access to the acquired resistance related variables, like the new mutations or copy number loss? How do we track that? Do we need to have always biopsy to have access to that information? Or can we use blood to get that information? So that's sort of the next question, the next grant, the next question we need to answer. And my question to the author is, I get the new acquired mutations, but what about the pre-existing mutations? Can you show them what they are, and can you combine that plus the acquired information to better predict who's going to have acquired resistance or not? Did they mention anything about the pre-treatment?
I believe these are the pre-treatment driver mutations. It's here.
Okay, but they didn't go in depth whether, so I guess all the genes listed on the left side, I understand that they are all acquired.
Right, yeah. So they didn't list out everything. It was just like the acquired mutations and then the driver mutations that were at baseline.
Right. For baseline, they only disclosed 6 genes.
Right, yeah.
So my question is, with the comprehensive genomic profiling they have, they've done NGS, the pre and post, and compared. So that's how they got this data. But did anybody have baseline STK1? You know what I mean? Did any, that's common. I see that in my clinic all the time. Some people have KEAP1 at baseline. They're just saying these are the acquired changes they see, correct?
Yeah.
Right. But in this article, they're ignoring like the impact of the baseline. Or did they mention that?
Maybe in supplement. I can look for it.
Oh, that's cute. Cute figure. Oh, what about this?
Oh, this is just among the control cohorts, the
Oh, control.
email
Okay.
targeted, yeah. Yeah, I don't see it. This swimmer spot. Yeah, just the driver mutations. Yeah.
Okay, so
Yeah.
can you go back to the very first, that table, on the main figure, the box, not the box, the most, yeah, this figure. So what's interesting is you can see the driver mutation A. What is A?
Elk.
ALK, and then MET, B is BRAF, KRAS. So there's no E here, right? We don't give immunotherapy to EGFR mutated patients. So
There's one E.
oh, okay.
Oh.
That patient got what the E?
PD-1 plus chemo.
PD-1 plus chemo, okay. Yeah, so it's rare. Maybe it's done under trial. Yeah, but I'm surprised there's a lot of driver mutations already here. Hmm. Hmm. So can you go to the summary? Yeah. So the authors list STK11, B2M, APC. Isn't APC interesting? APC is usually in colon polyps,
Mhm.
but it's not uncommon in non-small cell lung cancer. Can you go back to that table and go to APC? So there's deletion, insertion, deletion mutation, and missense. So APC, as you all know, is a tumor suppressor mutation. So yeah, I mean, and then it did not, and in the other group, it did not show any mutation or copy number loss. So I think that's really, really interesting. Yeah. Hmm. So therapeutically, how do you avoid this phenomenon and really work on potentiating the durable response in patients getting immunotherapy? How do you can you suppress a clone from having mutation? It's called selective pressure. Can you stop that from happening? No, you can't. There's no technology there. Then what can you do? What can you do? I think you can detect it early and give something to overcome this from happening. So there's something called sting agonist, STING, sting agonist, that boosts the immune system. Even if there's a problem with HLA-1, beta-2 microglobulin, it just boosts the immune system. STK11 keep 1 does, and the SMART4 loss of function is much more common than we thought here. So when it happens, how do you reverse that? Those are more epigenetic regulators. So something like EZH2 or 1 dual inhibitors can maybe, or HDAC inhibitor, the epigenetic regulators can may be able to work in that pathway. JAK1/2 as well. JAK1/2 is more tightly related to the IL-2 pathway, so that might be a way to overcome. So combining PD-1 with all the other pathway inhibitors may be the right way to go. And I think that's why a lot of people are trying to develop combos or bispecific. Sally and I attended meeting with Hanmiyakpum this morning, and they're developing a lot of good bispecifics like 4-1BB and PD-1. They have the world's first bispecific agent. So understanding what are the new emerging mutations first. I don't know if it has to be a biopsy or whether a more sensitive blood DNA assay can give us that information. Either case, we add a agent that will act on that pathway to prevent acquired resistance. So I believe that's the right next step. Design a clinical trial that identifies the resistant pathway and add that agent to overcome resistance. So that's the next step in my mind. Now, research-wise, I would love to do similar studies, but I hate to get my patients to do all like acquired biopsies. It's so hard. So really the compromise is still use the preclinical pre-treatment variables to predict the study outcome, knowing that there is a substantial limitation. Like we have to know the acquired changes that are occurring in patient's body as represented here in this article. So I've been a proponent of the concept of dynamic biomarker. Like baseline biomarker alone will never give you a complete prediction of what's going to happen. You have to give the drug and get the biopsy or get the blood and figure out whether it's really working or not. Maybe one time is not enough. That's why our biomarker studies are doing blood draws every 3 to 4 weeks. That's what Liam and I have been working on to get it set up. Because the dynamic changes are what should drive our treatment decision. It's not one-time prediction. It's not. That's why we do CA, CA-125, all these measures. We follow the tumor markers, and they help us make decision. Should I give this chemo or stop it? Or should I give combo? Should I give immunotherapy? You know, we just need to give clinicians, oncologists, more information so that they can make a more informed, more ethical, wiser decision. So that's the future of personalized medicine. So this is where we're kind of confined to this notion of PD-1 based therapies. Now there is a magnetic electric field treatment. Now there is CAR T therapy where we engineer T cell and infuse that T cell into patient's body, which is also to me a revolutionary. It changed the field of leukemia and myeloma. It's coming to solid tumor. Northwestern has come up with a technology to bring CAR T therapies into solid tumor world. It's just been published by Dr. Chae at Northwestern. So I'll send you the article. And you know, one of the experts described as a discovery of penicillin in the field of oncology. So that's how impactful this paper is. And I will send to you guys, and feel free to read it. And Haesung, this will be your next journal club paper. This is a revolutionary paper that will transform the field of oncology. The CAR T, we have CAR T therapies here, but it's been very difficult because of immune related side effects. We call it cytokine storm. But you know, there are logistic barriers. Cell therapy is not, it's hard because you harvest cell, you engineer it, and you put it back into patients. And the time to engineer and all these things are very difficult. You really need off-the-shelf therapies, even if it's cell therapies. So I want you to be aware, all the lab members, of what's coming. You know, where I see my lab as more personalized medicine, personalized oncology lab. And wherever the need is, we strive to make more data and change the practice. We're doing that in transplant oncology field. We're trying to do that in a niche where, you know, subtype of disease are being neglected. We believe that's the lipidic mucinous script. That's why we're trying to produce more data, make trials, target them. CAR T is the upcoming future. We want to learn about it as much as possible. So we'll let you know. But yeah. So my second comment is there are many things that's happening outside our traditional view of oncology, you know. So let's keep our eyes open. My plan is to do more of these journal clubs so that we can all learn together. Yeah, and learn together and study together, more like a study working group. I think this is a better model than, you know, you just know your own field project, but really use this chance to learn, and, you know, what can we learn from this, how can we improve these type of projects. So, okay, any questions or about anything before we wrap up? Okay, so we'll wrap up here. And Liam, I will talk to you separately, and Hesong, you can come and we can talk about the rest of the comments from Dr. Kurdra. Okay?
Sounds good, thank you.
All right, see you soon. Bye.
Thank you.
Thank you.
Yeah.